The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hello, everybody, and welcome back to the FlightBridgeED MDCAST. I'm your host, Mike Lauria. I am a critical care, emergency medicine, and EMS physician focusing on critical care transport. And welcome back to our OB critical care series. Today we're going to be talking about hypertensive disorders in pregnancy, from everything basically, from gestational hypertension all the way up to the dreaded eclampsia. We'd like to welcome you back to the series, and remember that this whole series was essentially born out of this unfortunate situation we see in the United States, where we're having worsening maternal mortality over the past several decades. In fact, the United States has slid to 65th in the world in terms of OB mortality and come up from about 7.4 to 32, almost 33 total deaths per 100,000, which is unfortunate. Compared to the rest of the world, we're not doing so hot in this area. And as many of you in the audience have experienced, a lot of these very sick moms are being transported from very rural centers with limited capability to larger tertiary and quaternary care centers. So we're going to see these patients, if anything, more and more frequently. And this podcast is designed to focus on just that. I also want to emphasize that critical care for these patients does not stop at delivery. Once baby is out, it's not necessarily curative, and we have to be able to manage these moms that actually give birth at outside hospitals even after they deliver and are brought to some of these centers. And as always, I'd like to welcome back Dr. Elizabeth Garchar. She's a maternal-fetal medicine specialist and also one of our flight physicians with our program. So she has a very unique perspective on this area, and she is helping me again with this series. As always, both Dr. Garchar and I have no conflicts of interest, and we will be discussing the evidence in our practice, but it is not a substitute for local protocols, guidelines, regulations, or laws. So always, please pay attention to your local laws, protocols, and guidelines. So to kick it off, hypertensive disorders of pregnancy have a really wide range of all sorts of different levels. And the distinction between some of them, sometimes it's nomenclature, but sometimes the management is the same, but sometimes it's not.
Yes, count on us MFMs to make it as complex as possible for nomenclature and different distinctions.
Yeah, absolutely. We tend to do that in academics sometimes. But let's just hop right into it, Liz. So let's go over exactly what is hypertension in pregnancy. And as someone who specializes in dealing with these conditions, how do you really define it?
Yeah, so hypertension in pregnancy is really defined as a repetitive sustained blood pressure of 140/90 or higher after 20 weeks, 0 days of pregnancy or later. If you're earlier than that, you really have chronic hypertension, and that's something that we try to allow diagnosis of in the patient setting or in the prior to pregnancy setting. But young, healthy ladies are kind of known for not going to the doctor. So oftentimes we'll look at just sort of their blood pressures on their early clinic presentations prior to 20 weeks. And that really throws a wrench in all our other diagnoses, as severe features without chronic hypertension can really be determined by blood pressure alone. But if you have a known diagnosis of chronic hypertension, then you're really going to have more sustained severe range pressures for us to call it preeclampsia with severe features. So going back to the actual diagnoses. So if a person only has hypertension between the values of systolic of 140 and a diastolic of 90, and a systolic of 160 and a diastolic of 110, either one, doesn't have to be both, after 20 weeks, but no other severe features, meaning we drew labs, we looked at their urine, and they don't have anything else that's different or abnormal, then they only have gestational hypertension. Let's say they have that same hypertensive range, 140/90 to 160/110. But when you do either a 24-hour urine, you get 300 as your proteinuria level, or you do a random protein to creatinine ratio and you get 0.3 or higher, then they have preeclampsia without severe features. And so that just means that all of their other lab work is totally normal. Really, the main distinction between those is that protein, and that's it. There's really no other differences. Both of them, we're going to do labs every week on these patients, and we're going to deliver them at 37 weeks. So this is purely nomenclature.
Gotcha. Okay. So that helps wrap our mind around who's who. But from a critical care transport perspective, kind of thinking about the spectrum, who or which of these patients are our flight crews most likely to see?
Yeah, so most likely to see people with preeclampsia with severe features. So this can be, like I said, if people don't have chronic hypertension, if you have blood pressures of systolic of 160 and diastolic of 110, either one only, that are sustained for at least 15 minutes, you don't need any other diagnostic criteria to meet preeclampsia with severe features. If you, let's say, have more mild range blood pressures, aka between 140/90 systolic and diastolic and 160/110, then you can also have any symptoms of organ dysfunction. Specifically, that would be a platelet count of less than 100, a creatinine of 1.1 or double your baseline. So if you have a baseline creatinine of 0.8, or actually, and sometimes in pregnancy, we'll see it being 0.4 or even lower than that, just doubling of that. An AST or ALT of 2 times the upper limit of normal at your lab as well, pulmonary edema, or a new onset unresponsive headache to medications that we can't account for with alternative diagnoses like known history of migraines or other things, or if they have new onset visual symptoms. What I tell people about is like a flash in their vision. So all of those are severe preeclampsia diagnostic criteria. You don't need to have necessarily anything except a mild range blood pressure and any of those other lab values at that point. And as you can see, one of these things is not necessarily like the others. So one is purely subjective, aka headaches, visual changes. If the patient tells me I have a headache that's not changing and their blood pressures are in the mild range, even if we try medications and they can't get rid of it, we have to deliver at that point. And this is something that gets into a lot of arguments for MFMs, because do we know if patients are just saying that because they're tired of being stuck in the hospital forever? You know, we got to believe our patients 100%, but it's really hard when you're going to have a very preterm baby as a result of that.
So our crews may actually encounter patients that meet some of the criteria that are very clear, but some of them might be getting transported because of very subjective criteria, like ongoing persistent headache in the setting of some of these other findings.
Exactly. Totally.
We have definitely discussed some very rare topics on this podcast. So peripartum cardiomyopathy, maternal cardiac arrest, God forbid. But how common is this? How common are these hypertensive disorders of pregnancy?
Yeah, definitely. So this is one of the leading causes of maternal and perinatal mortality worldwide, with an estimated incidence of 2 to 8% of all pregnancies. But if you look around the world, it's not exactly the same. So in places like Latin America and the Caribbean, it's responsible for a staggering 26% of all pregnancy-related death. We fare better here in the U.S. with a rate of about 16% of deaths related to hypertensive disorders of pregnancy. But the incidence is also, as with all of these things, increasing significantly, with an increase of a quarter from the late 80s to the 2000s.
Wow. So that's still quite a lot of pregnancy. This probably is, I would say, the most common thing that we've talked about so far, as opposed to some of the other topics. And to our friends in other places flying around the world and doing critical care in Latin America and the Caribbean, this could be a very, very common thing that they may end up seeing.
Definitely.
And so let's say that now this person walks into a small outside ED, this young female who's pregnant now walks into this small critical access hospital. How does an outside provider formally diagnose them and say, yes, they have preeclampsia with severe features and we definitely need to transport this person?
So if a person with a uterus who is pregnant at 20 weeks or more and also up to 6 weeks postpartum, which is something I always emphasize to my ED folk to ask if you've been pregnant recently, has a blood pressure of 140/90 or higher. You should always suspect a diagnosis on this spectrum. Because it's such a prevalent and has high rates of morbidity and mortality, I'd urge you to consider this diagnosis, but specifically if their blood pressure is over 160/110 until proven otherwise. So if someone comes in and they have these high of blood pressures, even if they came in for things like UTI or other stuff like that, make sure to rule out preeclampsia in that setting. And that's something that's really important to consider, like say, even postpartum.
Yeah, I cannot emphasize that enough. And I think we've harped on that multiple times on different episodes, that again, it doesn't just stop when baby comes out. A lot of these conditions, from some of these hypertensive disorders to peripartum cardiomyopathy and some of these other things we've discussed, they can happen after delivery. And so don't be tricked by, baby's out and mom's presenting a couple of weeks after delivery. Awesome. So this I'm so excited about because I really want to get your opinion on this and hear how you explain things. Because as a paramedic, as a flight paramedic, and even as like a medical student going into residency, the pathophysiology underlying this whole process just completely escaped me. But once I put it together, it kind of made sense where all these diagnostic criteria came from and why we look for different things, and then how we manage it. So Liz, would you mind just taking us through the pathophysiology of these hypertensive disorders?
Yeah, so we're not sure exactly what causes it, but there's several proposed mechanisms that all kind of work together exactly and come together. So some of the things that we think about are chronic uteroplacental ischemia, and so just not having enough connections, and that can be from actual placentation. So when this embryo got into mom's uterus, from then on, there was never correct connections with the placenta, is how I sort of explain it to patients. Another thing is the immune system maladaptation to this growing foreign body. So this has to have half of dad's DNA, right? And so you have to have a lot of foreign bodies as a part of pregnancy. And so your immune system could be attacking that foreign body. Another thing they looked at is VLD lipoprotein toxicity, so actual implantation hormones and specific different lipoproteins that are involved in implantation and an invading into the wall of the maternal uterus, actually causing toxicity. Genetic imprinting, so there's a lot of questions we ask all the time if the father's mother had preeclampsia or not, because that is a huge part of, we think sort of like in a way, the placenta contributing to preeclampsia risk. Increasing apoptosis or necrosis of trophoblasts as the pregnancy progresses. So throughout pregnancy, the reason we can test for genetic disorders of the baby by doing mom blood draws is by looking for those trophoblasts that have been processed by the maternal body and are broken down and spread throughout the entire body. So those increasing amounts of that necrosis could really be triggering to the body. Also an exaggerated response to these trophoblasts as they circulate. Another thing that they looked at was imbalances of angiogenic factors, with recent experiments demonstrating that causing a chronic uteroplacental ischemia. Specifically, it was just published in 2022 in the Green Journal, and it's talked about, currently believes that there's abnormal placentation in as early as the first trimester in women destined to develop preeclampsia. Although the etiology of the abnormal placentation is being debated, numerous epidemiologic and experimental studies really show that these imbalances in circulating angiogenic factors released from the placenta are the reason that there are maternal signs and symptoms in regards to preeclampsia. Things that they studied in this particular article, we're looking at levels of soluble FMS like tyrosine kinase 1, which is an anti-angiogenic factor, and that this is markedly increased in women with preeclampsia. Whereas free levels of ligand, placental growth factor, are also markedly diminished. So the good things are low, and these things that cause you to have more of a response are increased. And alterations in these angiogenic factors precede the onset of your clinical symptoms of preeclampsia and do correlate with disease severity in this particular study that they did. And I would say that honestly, the most likely thing is sort of a combo of all of the above. So if you are combining things, so like if you do a combination of intense vasospasms due to increased prostacyclin, thromboxane A2, nitric oxide, and endothelians, then you're going to be increasing your amount of your circulating angiogenic factors. And then you're also in pregnancy going to have just a increase in your overall body water, and you get a decreased colloid oncotic pressure capillary leak from these increased levels of your prostacyclins, thromboxane, and all of that. So then what happens? You end up with a really hemoconcentrated patient because you got rid of all of the excess water. You have this leak into your surrounding tissues, and you don't have a whole lot of intravascular fluid. So you're going to give vigorous fluids, but it doesn't replete your intravascular space. It only increases your pulmonary edema and your third spacing because of this leak that you already have. So one study to look at that used invasive monitoring in pregnant women in the third trimester with diagnosed preeclampsia with severe features, and found that aggressive fluids just led to an increase above normal of the capillary wedge pressure. So you're increasing your risk of pulmonary edema if you're flooding these patients with fluid. The other thing I found really interesting was that AST is the primary liver marker that's elevated due to periportal necrosis. And this is the first one that's going to be elevating more than ALT and preeclampsia. And we think of that again as like these circulating factors are leading to a necrosis due to this higher levels of these circulating factors. And then you also have LDH elevated for the same reason. So you have an ischemic necrotic liver due to the preeclampsia that can preclude the actual diagnosis criteria and lab changes that you're going to see. And late in preeclampsia, you can have elevated bilirubin from that hemolysis. And you also have in PT, PTT, and fibrinogen altered due to preeclampsia if it's left totally untreated for some time. The last commonly affected organ system that you need to think about is the kidney. And you have your glomerular endotheliosis with swollen endothelial and mesangial cells. And so you end up with protein deposits from the glomerular filtration and tubular casts in the setting of all of these circulating factors in the body. This leads to proteinuria. So then you end up with non-selective proteinuria as the pores are open. So most large molecules can fit out at this point. You also see decreased calcium in the urine as the tubules are trying to reabsorb their calcium. Just like all the other vasculature, the kidneys will vasospasm from this preeclampsia. So you have a 25% reduction in the glomerular filtration rate at that point. So you have oliguria of less than 100 mils in 4 hours in labor, and even in the first 24 hours postpartum. So you have all this extra fluid that's sitting in your extravascular space that's not getting out because you can't get it back into your intravascular space. And then you also have a decrease in your kidney function. So you end up with a really common route to AKIs and lots of affected organ systems between the vasospasm as well as the decreasing amounts of fluid.
Wow. So that was a tour de force of the pathophysiology of hypertensive disorders and preeclampsia in pregnancy. But I just find it so cool that this very complex, multifactorial reaction and or aberrant physiology secondary to the placenta being there causes all of these, or this placental implantation causes all of these vascular issues and maladaptive physiology, I guess, like all over the place. And I think when you think about it in the context of how Liz explained it, you can see why or how some of these things develop when they seem either remote or perhaps not necessarily directly connected to, not directly connected to the placenta, if you will. It's somewhat overly simplistic, but putting it all together. Now, so let's say, we have essentially we always think of it as a maternal problem, right? The features manifest in mom with all sorts of different things that we talked about, but there's, like always, a second patient. So what happens to the fetus under these circumstances, and how does preeclampsia affect the growing fetus?
So the fetus also suffers. So again, there's a lack of a physiologic transformation of the spiral arteries in the first or early second trimester. And so you should have, I say, like a big open highway where you have connection of maternal and fetal blood. So you should be giving the baby all you got. But when you have these narrow streetways, so to speak, of like a lack of spiral arteries in that point, then you end up with fetal growth restriction because you just don't have the same amount of nutrients. You also would end up with the baby not being able to make urine either. And so you end up with low fluid or oligohydramnios. And when you have low fluid, one of the problems you can get from that is also having like sort of a tearing of it. Although more commonly, you get abruption in the setting of high pressures. So these high pressures can bust out these babies' arteries and lead to placental abruption. You also can commonly see, especially if you're having abruption or late signs, babies that look really terrible on monitoring. So you might need preterm delivery just due to a lack of good surveillance, so a non-reassuring fetal status. And that is something to watch out for. Also, babies can die of these high pressures and of untreated preeclampsia.
Wow. So we kind of knew it was bad for baby to begin with, but I think that's a really great explanation and brings it home of the effects in mom, but also why we see those manifestations in the fetus and things that even our crews now, especially with tools like ultrasound, can potentially be on the lookout for. So now let's get out of the nitty gritty. The thing that everybody really, really wants to know is, how are we going to go about treating this? So we have this young lady that is presented to a small rural critical access emergency department, coming to a larger L&D center that has maternal fetal medicine specialists and a NICU. How are we going to manage this patient in transport?
Yeah, so as I alluded to, just for completion, both gestational hypertension and preeclampsia without severe features, they can give me a call, but both are mild things with outpatient management. So the transported group, the preeclampsia with severe features, will require inpatient management until delivery and preterm delivery. With delivery considered the primary end goal if you are over 34 weeks. So if a woman presents and she's at 30 weeks, we're going to try to get her to 34. But if she's over that, it's time to have a baby. The cornerstone of medical treatment of preeclampsia with severe features is magnesium sulfate. The study that everyone brings up when they talk about magnesium in this context is the MAGPIE study, which was from 2002 and included 10,110 participants, what a great number, from developing countries and other high-resource places, and found that mag sulfate decreased the progression to seizures or eclampsia by over 50%. So I imagine how the people who came up with that study felt about that kind of statistical power. It must have been amazing. But oddly, though, when you stratified out women in Western or high-income countries like our own, there was actually no statistically significant decrease in their rates of eclampsia. So what was done to look further? We looked at a meta-analysis in 2010, and that showed that magnesium more than halved your risk of eclampsia, decreased the rates of placental abruption, and modestly, aka it was not statistically significant, but something they talked about, decreased the rates of maternal death. What's the downside of magnesium sulfate? Primarily hot flushes, and also a 5% increase in cesarean section rates. For a long time, magnesium was used as a tocolytic, and some people still use it that way, I'll admit. And so it does decrease your contraction, so it makes sense that you increase C-sections. But what about too much mag, right? Especially in a population I just talked about them having decreased GFR, decreased ability to process things through your kidneys, and that's how you get rid of mag. So let's not forget about magnesium toxicity, which leads to, the cessation of breathing and respiratory rest. So how much do you give? In proper OE fashion, we don't have a consensus. The quotic therapeutic range that you can read is from 4.8 to 8.4 or 8 or 9.6. Again, you get the idea. There's lots of different stuff. I usually use 4.8 to 8.4. It memorizes well in my brain. Seizures can still occur when you're in this range, but studies using an infusion rate of 1 gram an hour after a bolus of 4 to 6 grams showed a huge decrease in eclampsia. But if you actually tested their magnesium levels, they remained subtherapeutic with this regimen for many, many hours, and most people were still subtherapeutic under 4.8 with a average serum magnesium of about 3. Also, as obesity becomes more prevalent, it's estimated that a 4.5 gram loading dose and a 1 gram an hour rate will leave a patient with a BMI of over 35 subtherapeutic for a whopping 18 hours. So what's right? Well, what the literature consistently shows is serum levels correlate with toxicity. So do turn the mag off if they have a level of 8 or 9, but it doesn't correlate with what's actually going to help prevent a seizure. So if they aren't seizing, maybe don't turn it up either, even if their level is at like 4. So the exception is if you're intermittently bolusing. And I do that in a setting where someone has a lower GFR, or if you did, the reason they have severe features is because their creatinine is 2 or something like that. So if their creatinine is higher than 1 to 1.5, or they have an oliguria due to a loading dose, then you should really consider just bolusing only. Also, don't go over 2 grams an hour as a rate, as that has been shown to increase perinatal mortality as well. What ACOG specifically says is in the guidelines, and the thing to do is a 4 to 6 gram bolus followed by a maintenance dose of 1 or 2 grams an hour. And so again, whatever your local protocols are, whatever your hospitals are comfortable with, as long as it's in this range, is reasonable. And that this should be continued until 24 hours after delivery if you're 34 weeks or greater, or until you are stable if it's earlier than that. So if a mom presents at 30 weeks, I'm going to keep her on MAG until I'm pretty sure I'm not going to deliver her in the next few hours. And also consult your friendly neighborhood MFM. So I would say, again, a 24-hour dose rate is probably what you should be thinking about. What if you don't have an IV? What if they just pulled out the IV as you loaded them on the sled, which I have maybe done once or twice? Then you can do 5 grams in each buttock for a loading dose of 10 grams IM, followed by 5 grams every 4 hours. They're probably awake and talking to you, so really be kind. They recommend mixing it with xylocaine 2% or the equivalent, as it's an extremely painful, very heavy injection. So now I talked a lot about toxicity and monitoring with serum levels. So what if you run out of your portable chemistry cassettes, or you don't have that capability, you can't be looking at their MAG levels? Then use your physical exam in that case. So deep tendon reflexes are lost at a serum MAG level of 9, with respiratory depression at a level of 12, and cardiac arrest at a level of 30. So go to the bedside. I use my stethoscope. I don't have a fancy reflex hammer. But if you have one, great. Get your knee reflexes. I also flex back the foot, to look for clonus, but also to see what their baseline, reflexes are at this point. Some people like to do brachoradialis because you can get to that a lot easier. You don't have them all bundled up. And that works totally fine as well. And you'll find that probably they're hyperreflexic when you first see them. A few beats of clonus is really common, but it's a good way to see if they don't have any later that you're having problems at that point. Another thing to do, take that stethoscope back and listen to lungs for signs of pulmonary edema, and hear baseline breath sounds, although that's going to be tough on the road assessment, that's for sure. Unlike reflexes, where you can do that even if you're in a really loud environment. Another completely crucial thing to watch, the whole transport, is urine output. So the only way MAG gets out of the body is through the urine. So if you have a 100% urine output, is a vital sign of preeclampsia, and it's something that should be charted hourly in the outpatient setting, inpatient setting, and so something to watch out for. Let's say they're losing respiratory effort. As with all patients, prepare to intubate, but also get your calcium gluconate 10% solution, and push over IV over 3 minutes. ACOG recommends adding furosemide IV to accelerate the urinary excretion of the magnesium. So if you're having toxicity, you're pushing your calcium gluconate, use it if you have it.
Wow, that was awesome. That was that little section could be re-entitled "Everything You Want to Know About Magnesium Administration in Preeclampsia." That was awesome. I mean, I took when we were first going over this, and you were sending me some of this, the really interesting thing that I took away from this, because this has happened before in transport, is patients have been so swollen that the outside ED or sending facility was like, we couldn't get IVs, or their IV pulled out when they got to the side of the bed and tried to go to the bathroom or something, and they had to stop the MAG infusion. And it's like, well, what do you do then? And so I thought this was really, really neat, the ability to do it IM. Although I personally, I'll admit, I have not done it. It does seem like a pretty big volume. So I love the tip about the xylocaine or the lidocaine 2%, because I think that's probably important to help these poor ladies out. And then I think the other thing to take away, and the one thing that you pointed out, Liz, was the magnesium administration in relationship to their kidney function. Because, I mean, I in adults, and it seems like across the board in pregnant women in critical care, if you have normal kidney function, sometimes I find myself like trying to get them therapeutic, and it's almost hard if they're peeing out that much. Like you really have to load them, and you have to keep that infusion, to really get them in a therapeutic range, because your body pees out magnesium pretty well. But we've definitely seen a couple cases where it looks like they start out okay, and over the course of maybe a day waiting for transport because of bad weather, or a couple days being admitted before they got to the sending facility or the receiving facility, that changes. And even intra-transport, we've noticed like, hey, things were going pretty well, but if you look at their urine output over the past few hours before you got there, it was actually decreasing. And those are the patients that I think the hairs in the back of my neck stand up, and I'm particularly careful about clinically monitoring them for signs, because I think we've all been at the bedside, and, you know, it's going to take a while to get a mag level. And as I recall, most of the iStats and devices, I'm not sure about that, but don't measure a mag level.
Yeah, exactly.
So you can't get it. So it's really like your clinical suspicion based on their trajectory, and really watch them close for toxicity. So I think we should always encourage our crews to keep that in mind. Okay, so we talked about everything magnesium, but the other big piece in every guideline and protocol, book, chapter, etc., is how we manage their blood pressure. So, Liz, if you wouldn't mind taking us through how you approach it and how you think our crew should be managing blood pressure in transport.
We have 3 go-to drugs for pregnancy, and those are nifedipine, which is PO only, labetalol, which can be IV only. You do have a PO option, but IV only for treatment of preeclampsia, severe range blood pressures, or hydralazine, which again should be IV only for this use. And this is really a balancing act. The goal is a blood pressure of less than 160/110 only. You don't want to get down to a normal low range or anything like that. In this acute setting, that's our goal. And it's bad for baby to be hypotensive as well. So if you give them, especially nifedipine or something, and they're getting really low, you can also end up having a really bad tracing from that. So we don't want to do any of those things. So in an acute transport situation, if you have a blood pressure of over 160/110 on either number again, the goal is to get below 160/110 within 30 minutes at absolute most. So let's say your first reading is 170/100, repeat in 15 minutes. Let's say that next one is 160/90. It's time to treat immediately at this point, because you have a sustained severe range blood pressure. And have your drug of choice on hand and ready to go when you repeat the blood pressure, ideally. My favorite out of hospital, easy to go to medicine is nifedipine, because it is oral and it's immediate release. And when compared in a, I'll admit, somewhat small trial, oral nifedipine actually worked faster than IV labetalol by about 10 minutes in reducing your blood pressure. And it's also, again, oral. So as long as a patient is conscious and chatting with you, it's a lot easier to give than IV meds, unless you have an IV and all of those things. I would say that the range of dosing can be dependent on facilities and definitely something to chat about. But again, my favorite one. If not, you always have your second agent, my second favorite, labetalol. And most hospitals have a protocol of how to step up both of those, or that medication as well. If you look at ACOG's recommendation, speaking of dosing regimens, then your recommended ACOG dose of oral nifedipine is 10 to 20 milligrams orally every 20 minutes with a max daily dose of 180 milligrams. Most places that we see go up to like 30 at a time, but it just really depends. And this is what ACOG says is the recommended amount. Also per ACOG, labetalol should be 10 to 20 IV, then 20 to 80 every 10 to 30 minutes with a max dose of 300 IV, or you can also do a constant infusion of 1 to 2 milligrams per minute. I didn't mention hydralazine yet, but the ACOG recommended regimen for that is 5 milligrams IV or IM, they actually say, although I've never seen it given IM here, but that doesn't mean it's not a thing. And then 5 to 10 IV every 20 to 40 minutes. So you have a max of 20 milligrams, or again, a constant infusion of 0.5 to 10 milligrams per hour.
That was awesome. And I think one of the things that you really taught me in this particular is when you showed me that study about the oral nifedipine versus the IV labetalol. Again, as you pointed out, the study has some limitations, but I think in going through it and reading through it, at least tells me that it is, at the very least, it's not inferior to IV labetalol. And often, I think what we found, especially in talking to our OBGYN colleagues at some of the receiving facilities, is that traditionally we always think in critical care transport, IV. And if you look at a lot of protocols and a lot of the teaching in the past has always been like, hey, it's IV hydralazine and labetalol, and that's what you do. But this is actually, I think, a much nicer way to do it because we don't necessarily need IV access. You can give it to them orally. And if there's no contraindication to taking oral medications, that's often, correct me if I'm wrong, often what they will continue on in the hospital.
Right.
So I think it's a small sort of nuance point, but you could say that by starting it at the sending facility and getting an idea of how they respond to like 10 or 20 milligrams, that can be very nicely continued during their inpatient stay. So I think that's a fantastic way to go about it. So we talked about everything magnesium. We talked about blood pressure control, but let's hit the most dreaded presentation of these hypertensive disorders in pregnancy, which is eclampsia. What should we be on the lookout for, and what do we have to do to manage eclampsia, Liz?
Yeah, eclampsia is definitely the most dreaded, and it is the convulsive manifestation of hypertensive disorders of pregnancy and is extremely severe. I have to emphasize that it's not always the end result of an untreated preeclampsia. In fact, progression's unusual, but it could be the very first symptom someone has. So this is especially more common in certain areas of, especially the country. People will come in, they've had normal pressures their whole pregnancy, and they present seizing, and that's the very first sign that they have any hypertensive disorder of pregnancy. I'm a history buff, so I have to add in there that it's also one of the oldest described complications of pregnancy, with writings even by Hippocrates in the 5th century BC. Also, fun fact, humans are the only animals that can get preeclampsia. So to make animal models has been really, really difficult. So it's hard to study in non-humans. Eclampsia is a significant cause of maternal death in low-resource settings, particularly with hypoxia, trauma, and aspiration pneumonia as a result of not being able to manage the airway and those kind of things as well. And there are not short or long-term cognitive impairment from eclampsia itself. So they shouldn't have really much of a post-ictal state whatsoever. But MRI does demonstrate that you can have up to a 25% white matter loss in patients who experience eclampsia. So you should be able to do a good post-seizure neuro exam if it's truly an eclamptic seizure, assuming that you don't, need to give them other medications to try to break the seizure or, quote unquote, snow patients. So do be careful about medication use. So eclampsia is often preceded by premonitory signs, especially photophobia, altered mental status, blurred vision, or even phonophobia as well. But it's not the case for everyone. So up to 38% of patients, like I had said before, can actually present with a seizure as their very first sign. So that's another reason why if someone comes with preeclampsia and they have headaches or changes in their vision, to be a little bit concerned that they might seize on you as well.
One of the things that I cannot emphasize enough to crews is this fact that they don't have to have a history of high blood pressures. And quite frankly, that's important in our area and a lot of others around the country, because sometimes these young women will come in and have no care previously. So the lack of previously documented high blood pressures does not exclude the possibility that this could be a first presentation and then this is eclampsia. One of the things that I was hoping you could comment on, Liz, is let's say the seizure's going on for a while. Like we'll talk about treatment here in a second, but let's say you treat it and it keeps on going and keeps on going and keeps on going. What should we consider?
Yeah. So, the main thing to consider is that there's something else going on. So what they say is that a lot of times, and the mnemonic that they've taught us is like, take both hands, put them in the air, and then put them under your butt to sit on them for 4 minutes to see if she'll stop seizing, because that's what should happen if you have eclampsia. But if you continue, then you're going to have possibly one of the dreaded complications of untreated preeclampsia or the eclampsia, which is like a hemorrhagic stroke from really high pressures, or obviously other intracranial causes. So also if they have a history of any seizures previously or even don't, you can also still have a primary presentation of epilepsy in pregnancy. So don't forget about other seizure things as well.
Gotcha. So I jumped ahead there because I really wanted to touch on other things that can cause seizures, because we do have to keep those on our radar. But what do we do if they start seizing?
Yeah, so eclampsia management is the same as management for anyone seizing. So first of all, prevent maternal injury. Place them in the lateral decubitus position. Left or right is not super important, if you can, obviously. Prevent aspiration, administer oxygen, monitor vital signs. Intubation is generally not necessary for an eclamptic seizure, but don't, forget the airway, and don't forget to be ready to intubate if you need to, if her sats are dropping. And they do drop generally much faster than their non-pregnant counterparts. If you have seen anesthesia intubate in a C-section, as I have several times, usually the sats are dropping within 15, 20 seconds sometimes, just because of the changes of the airway from pregnancy alone, and then add on a bunch of edema from preeclampsia or eclampsia, and you're going to have a real difficult airway. So again, we said, well, how about some phenytoin, diazepam, something? Nope. Magnesium has been studied, and it has been put head to head with those and nimodipine, and has been more effective for preventing really the next seizure. It's not that it's going to stop this eclamptic seizure, but it's going to keep you from recurrent seizures. So don't forget about that. The only other caveat, since we've talked all about MAG, I have to add the last thing, and the favorite OB board question is who can't get MAG? And that would be people with myasthenia gravis. So that's the only group of patients that you shouldn't be giving MAG to, because you're going to totally block them, and that's not good. So those patients, they actually recommend phenytoin or benzodiazepines as your first line treatment for an eclamptic seizure in that particular population. And you all would probably faster think than me, but you could probably should not do magnesium in someone who is profoundly hypocalcemic, and because that's also going to cause more seizures, which is a different problem. Other things to think about are cardiac ischemia, heart block, or myocarditis. But these are generally young, healthy women with no other problems. So it's things that I definitely don't right away think of as like, why shouldn't I use magnesium? But do take into account those history things as well, or just have your calcium gluconate on hand as well. Use magnesium sulfate and wait, I said. But what if the eclamptic seizure doesn't stop? It says to try to do, like I said, other things as well if you need to. Rarely patients get super aggravated in this setting of having this eclamptic seizure. And so what ACOG says is to do clonazepam 1 milligram, diazepam 10 milligrams, or midazolam for the rare patient that needs it after an eclamptic seizure, essentially because of their rowdiness alone. But this is super, super rare. So they don't really have a recommendation of, like trying to give prophylactic medications or trying to get people down, essentially. And ACOG actually defines refractory eclampsia as more than 2 recurrent seizures or still seizing at 20 minutes after the magnesium bolus. But I can't imagine why anyone would wait quite that long. 4 minutes alone feels like an eternity. So at that point, ACOG says reach for sodium aminobarbital 250 milligrams IV. And then the other things they talk about are phenytoin at 1,250 IV at a rate of 50 milligrams per minute as your next drug. Some people say give more magnesium too, but again, looking at your therapeutic range, is that really going to help? We're not totally sure. And you're going to need to think about the fact that you might cause respiratory depression, especially if you're doing it again.
That was a really good run through on the preeclampsia treatment, but let's bring it home with talking about another organ that unfortunately takes a hit when in preeclampsia and eclampsia.
Yeah, so the last thing to talk about is HELLP syndrome, or hemolysis, elevated liver enzymes, and low platelet count syndrome. And so the diagnostic criteria for that is adding in liver problems, essentially. So an LDH of 600 or more, and AST and ALT twice the upper limit of normal, or platelets less than 10,000. And this can be either in the third trimester or again can occur in the postpartum period as well. 30% of the time, it's actually first presentation is in the postpartum period. And so what's unique about HELLP and why it's kind of like considered on the spectrum, but not necessarily, is that you don't have to have hypertension or proteinuria at all in order to have HELLP syndrome. That's super rare. Only about 15% of patients will have that, and it's called atypical HELLP syndrome, but it is for sure a thing. So if you have pregnant or recently pregnant patient with generalized malaise, particularly if they present with nausea, vomiting, getting a CBC and a liver function test can help you see if maybe you have an atypical HELLP.
Gotcha. Well, again, that was an awesome wrap up with eclampsia and HELLP syndrome. But let's bring it home. And if you wouldn't mind leaving us, Liz, with some of the key pearls and things that you want to emphasize to our transport crews in terms of identifying and managing these disorders.
Yes. So I would say our pearl summaries here are gestational hypertension and preeclampsia without severe features are outpatient diagnoses with delivery at 37 weeks if all goes well. Preeclampsia with severe features is diagnosed in someone without chronic hypertension by blood pressures of 160 over 110 alone. So if they've always had normal blood pressures, all you need is high blood pressure for preeclampsia with severe features. What is the diagnostic criteria, though? Preeclampsia with severe features, if you have chronic hypertension or if you don't have those severe range pressures. So if your pressures are between 140 over 90 and 160 over 10, you need to have either a platelets of less than 100, creatinine of 1.1 or 2 times baseline, AST especially, but either AST or ALT 2 times the upper limit of normal, a severe headache unrelieved with medication, and or visual disturbances. Next thing. Treatment of pre-E in an acute setting is number 1, start MAG to prevent eclampsia based on your preferred regimen. Monitor for toxicity with refluxes and urine output. And if you happen to have MAG levels at the facility or something, you can always do that too. Also, don't forget to treat the hypertension if their blood pressure is 160 over 110 only with nifedipine, labetalol, or hydralazine. Eclampsia is the most severe form of hypertensive disorders of pregnancy and is seizures that result from the disease. You can have this as your first presentation. They don't have to present as a progression from preeclampsia, but they can. HELLP syndrome is defined as someone who is pregnant or postpartum with an LDH of 600 or more, AST and ALT twice the upper limit of normal, platelets less than 100,000, by the way. They often have hypertension, but they also may not. Also, preeclampsia postpartum is a thing, and patients with high blood pressure, all of them, should be asked if they've been pregnant in the last 6 weeks. Eclampsia treatment is also primarily magnesium sulfate. And if they're seizing for more than 4 minutes, consider other causes of seizures, things like having had a stroke, and also intracranial, other things like that, other lesions, besides eclampsia, and break accordingly. And last but not least, HELLP and postpartum preeclampsia also require prompt attention, and generally, my favorite thing, magnesium sulfate.
Again, MAG, more MAG, and a variety of other things. Exactly. That was awesome. Liz, thank you so much for taking us through one of the very common and very morbid things as it relates to critical care in obstetrics. And ladies and gentlemen, please do fly safe out there, take care, and join us on our next episode for the OB Critical Care series.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.